Okay, hello everyone. This is Emily Clark, Information Specialist for the NCCMT. I am a coordinator for this webinar series brought to you by the National Collaborating Center for Methods and Tools in collaboration with the National Collaborating Center for Determinants of Health. Thank you to those who have joined us for this webinar. Today we will be featuring methods and tools for integrating health equity into public health programming and implementation. Before we get started, I do want to thank everybody who did note the time change. We do apologize for any inconvenience this may have caused. And for those of you who may have colleagues who are unable to make the new time, a recording will be made available of today's webinar in the next few days as well. So we will quickly review just a couple of housekeeping items before we get started. You can see the chat section in the bottom right-hand side of your screen in WebEx. Please post any questions or comments that you may have during the webinar. We will have a designated open Q&A session at the end of the presentation, but please feel free to post any questions or comments that you may have during the webinar, and we will try and answer those as we move along as well. Please post your comments in the chat section to all participants, as other participants may have the same questions that you do. Today we do recommend using a wired internet connection as opposed to a wireless. And if you do have any connection issues today, you can either send a message to Claire Howarth, who is on the line for support, or call the WebEx 24/7 helpline, which is posted on this slide, and the number will be posted in the chat section as well. After today, the presentation will be made available in both English and French on our website. Links to the YouTube and SlideShare account can be found through the website, and a link for this will be posted in our chat section. We aim to have these posted within a couple of days of today's presentation. We will now have our first polling question of today. We are interested to see how many people are watching today's session with you. We're wondering if you've joined by yourself, if you're in a group of 1 to 3, 4 to 6, 6 to 10, or if you are in a larger group. You can answer this question in the poll question panel on the side of WebEx. And just remember to hit the submit button so that your answer is recorded. So it looks like most people are joining by themselves, but we do have one really large group and a number of smaller groups as well, and that's really fantastic, and we certainly hope that you enjoy today's presentation. For those of you who may be unfamiliar with the National Collaborating Centers, here at Methods and Tools, we are one of 6 national collaborating centers across Canada. We're all funded by the Public Health Agency of Canada. We here at the NCCMT are located at McMaster University in Hamilton, and the NCC for Determinants of Health are located at St. FX in Antigonish, Nova Scotia. The various NCCs focus on different topics in public health, for example, environmental health, infectious diseases, determinants of health, and here at Methods and Tools, we focus on the use of research evidence in improving the access to and the use of methods and tools for health professionals in practice within Canada across all different topics in public health. So I would like to formally introduce our presenters today. It is my pleasure to introduce Susan Snelling, who is a Senior Knowledge Translation Specialist at the NCCMT. Part of her role is to link public health agencies across the country with methods and tools for using evidence in their organizations, as well as deliver training related to evidence-informed decision-making. Susan worked for 10 years at the Sudbury and District Health Unit, where she was a manager of research and evaluation. She's also worked at Public Health Ontario, providing training and consulting on health promotion evaluation. Susan holds a PhD in psychology and has a credentialed evaluator designation from the Canadian Evaluation Society. We're also very pleased to be collaborating with Leslie, a knowledge translation specialist from the NCC for Determinants of Health in Antigonish, Nova Scotia. She's a health promotion professional with 12 years of public health experience in British Columbia, focused on organizational capacity building for health equity. Leslie earned her BA in Mass Communication at Carleton University and her MA in Health Promotion at the University of British Columbia. Also joining us today, we have two members of the Niagara Region Public Health in Ontario. Pam Loft studied nursing through Mohawk McMaster University's bachelor program, and she's currently a public health nurse in the infectious disease program at Niagara Region. She's involved in department health equity and supporting evidence-informed decision-making. And finally, Nina Jane Sheehan studied at the University of Toronto for a Bachelor's of Science and at Dieuville College for a degree in education. Currently, she's a public health policy advisor at Niagara, where she works on advocating for healthy public policy, such as smoke-free housing and a municipal concussion policy. She's also involved in departmental projects for health equity and evidence-informed decision-making. So thank you so much to our presenters today, and I'm going to pass it on to Susan to provide an outline for today's presentation.
Well, great. Thanks, Emily, and welcome, everybody. This is indeed Susan Snelling here from the National Collaborating Center for Methods and Tools. Just a quick outline of our webinar today. So the topic of this webinar is Methods and Tools for Integrating Health Equity into Public Health Program Planning and Implementation. We'll start with a very quick introduction to the National Collaborating Center for Methods and Tools and the National Collaborating Center for Determinants of Health. And then we'll get right into the key question: how can methods and tools for evidence-informed practice and those related to equity be used to advance health equity? We'll give just a few minutes on some terms and concepts, probably familiar to many of you on this call already, but just to establish some key principles related to evidence-informed practice and related to health equity. And then we're really excited to have the focus of the session today on examples from Niagara Region Public Health about the work that they have done. So the idea for this webinar arose from a discussion between NCCMT and NCCDH about crossover in the use of methods and tools to support evidence use and methods and tools to support action on equity. We know that public health practitioners want both to plan using evidence and to bring an equity lens into their planning. These two goals are integrated in the way people actually work in public health. They're not separate. So we wanted to feature some ways that people are using methods and tools to meet both their evidence-informed practice objectives and their equity objectives. It's not just the tools, as you will hear, but tools can help if used for the intended purpose to advance health equity and used in a supportive context. So really exciting to be hearing about these examples from Niagara Region Public Health. First of all, to understand the barriers and facilitators to the use of equity planning tools, and also about the use of the 10 promising practices for health equity in the local health unit context. After we hear from Niagara Region Public Health about their work, we will just briefly touch on some resources available from NCCMT and from NCCDH that may help you apply health equity principles to planning processes and contribute to an overall evidence-informed public health. And then we will have time for questions and discussion, and that will happen through the chat function. Of course, you can use the chat function at any time if you have questions, but the majority of our question and discussion period will come towards the end of our session together. So with that, I'll just say a couple of words then about the National Collaborating Center for Methods and Tools, or NCCMT as we call it. Our focus really is on the use of best available evidence for making decisions. So we look to support the uptake of what works in public health into practice. and then I'll ask my colleague, Leslie, to just comment briefly on or introduce the National Collaborating Center for Determinants of Health.
Yeah, thanks, Susan. Just briefly to say that we're really pleased to be here and really excited to be collaborating with a focus on evidence-informed public health practice and integrating equity. And the focus from NCCDH perspective is on the social determinants of health, so the social conditions that influence health, with our focus being on narrowing the gap between the least and the most healthy. And we'll get into a little bit more detail when we talk about definitions that we can use to inform our work. Our audience is basically everyone on the call today. We focus on our public health practitioners in Canada, whether you're at a senior level decision maker in your organization or whether you're delivering frontline public health practice. We do also work closely with researchers and other stakeholder organizations, but our main focus is to serve the public health practitioners in Canada. And of course, we are focused on bridging research to practice, and we're focused on evidence, but we're also focused on developing the processes and systems and relationships and collaborations that we need in order to create the social change we're looking for, in order to create the impact on the social determinants for health in Canada. So that makes us, in some ways, a little bit different than some of the other NCCs. So that's us at DH. So I'm just going to pass it back to Susan so she can provide a bit more background on the evidence-informed decision-making aspects, and then we'll jump into some definitions around equity and social determinants.
Great, Leslie. Thank you. So already I think a couple of times I've used the term evidence-informed public health, and so that really does provide one of the framing concepts for today's webinar. When I talk about evidence-informed public health, this is the definition that I'm using, the process of distilling and disseminating the best available evidence from research and context and experience, and using that evidence to inform and improve public health policy and practice. So evidence-informed public health really is a systematic approach to incorporating research evidence in program and policy decisions. We use this 7-step model for a process of evidence-informed public health. May be familiar to many of you on the call. I won't go through this in any detail, but just quickly to say that the sense is that evidence-informed public health has multiple steps to it. There are multiple skills that people need to do to really engage in evidence-informed public health. And the focus today, I think, is probably more on those latter parts, sort of the blue side of things. So adapting evidence to local context, implementing, how do we encourage people to find and use evidence and apply that in their settings. So this is one model that we find useful just to encapsulate all that we mean by evidence-informed public health. Another model that we often make reference to at the National Collaborating Center for Methods and Tools is this one. So we do certainly focus on building skills and capacity for finding and understanding research evidence, the bottom left component of this model, but recognizing that when people are making evidence-informed decisions, they'll be using not only research evidence, but taking into account community health issues and the local context, community and political preferences, and actions that have already taken place and may be taking place at this time, public health resources, both human and financial, and then tying that all together, public health expertise. People on the ground have a sense of what may be the right decision for their context at this particular time. So decision-making will involve all of these pieces, and I think we'll see that in some of the examples as we go through that to make decisions about planning, implementation, and bringing in an equity perspective really relies on bringing together insights from all of these perspectives. So I will pass to Leslie now to talk a little bit more about some terminology and concepts related to health equity. So over to you, Leslie.
Great, thanks, Susan. So I'm going to take about 5 minutes. I've got about a dozen slides. They were put together with the intention of being able to leave you with some core concepts and links. So I'm going to speak to them at a fairly high level. But of course, as we know, addressing equity and integrating equity is a many-layered endeavor. So I'm going to try to set the stage for us so we can reflect back on equity after we hear from the practice perspective that Niagara is going to share with us today. So in addition to evidence, or perhaps because we're often making decisions with imperfect evidence, we really need to know where we're going. So what does it look like when equity is integrated? So we really like to start with a simple framework, and we found that this model, often called the rainbow model, which you may be familiar with, it's been around for a while, is a really nice way to anchor ourselves. So if we think about health as holistic, as a state of complete physical, spiritual, mental, emotional, etc., well-being, then it becomes clear that health happens where we live, where we work, where we play. It's all around us. We need to take into consideration the social, the economic, the political, the ecological conditions that influence health and well-being. So these include everyday living and working conditions like income and work and housing and education and food. The nature and the distribution of these, however, are critical because they are influenced by the context in which we sit. So this is I think if you ask anyone about what keeps them well, so not what keeps them healthy, but what keeps them well, they will answer that question with those kinds of descriptions around the people and the places in their life. But of course, if we're trying to influence and support positive health and well-being, we need to pay attention to the underlying mechanisms. And this is when we start to bring in some of the interesting frameworks and models which you may be familiar with. This one, in fact, is a simplification of a framework that's used by the Commission for Social Determinants of Health that was put together by the World Health Organization. So again, if you want to spend some time in the weeds, I really would recommend you go and take a look at that. But for today, I just want to, I guess, focus on one key message, and that is that while the social determinants of health, so as you can see in the red circle, the determinants which often look like the list, which many of us are familiar with, the list of social determinants like housing and income and poverty and early child development and those education, things like that. Those social determinants are the things that impact us at individual and community levels, impact our health and well-being, but they are patterned. So the way that we access those social determinants, if we access those social determinants, they're patterned, they're distributed based on what we call the social determinants of health inequality. So they're patterned in unequal ways. And the things that pattern them are the political, economic, cultural, and social context, and then the social position of the individuals in the community. And as a result of that, the social determinants are not determinants that everyone has equal access to, and that then patterns the health outcome. And of course, this is further complicated by the fact that the social determinants you know, as we learned in doing our work on chronic disease prevention, you can't put a chronic disease in a stovepipe and think that you're going to tackle it. So you can't tackle heart disease separate from diabetes. The exact same situation exists for social determinants. The social determinants intersect and interact, and as such, the health of an individual or group is the result of a complex mix of factors. So this is where it starts to get interesting, of course, because we see differences in health status and we see differences in access to social determinants, but the key thing is that they're patterns based on socioeconomic factors, and these factors are socially created. And of course, because they're socially created, they influence people collectively in groups, and we can look at the way that these social determinants of health are accessed and socially created, and we can see that they are they influence groups in a systematic way, and we can see that in many cases it's completely avoidable, these differences between groups, and we can also see that the differences that we see in groups and health status and access to social determinants is in fact unfair. And that is important because that brings in a value judgment. So we're not just looking at differences in health status and differences in access to social determinants, but we're looking at the outcomes and we're asking ourselves, is this systematic, is this avoidable, is this fair or unfair? So the good news, of course, is that if the social determinants and health status is socially constructed, it can be socially deconstructed. And that is really the opportunity for us in public health to support the work upstream that needs to happen in order for us to ensure that everyone has fair access to the determinants of health. So for example, I've thrown in a couple examples here. The first example is related to food security, and this example comes from New Brunswick. And you can see in their data that food insecurity is much higher amongst people who are in the lower income quintile compared to the upper. And you can also see that there is a very clear gradient. So it's not that poor people have poor food security and everybody else has good food security, but you can see there's a gradient across the income. And this is why when you look at a lot of the work that's being done, so organizations like Food Secure Canada and the Ontario Association of Public Health Nutrition Professionals, they're working towards income-based approaches to improving food security. It's not sufficient just to focus on food, I guess is what we're saying from the perspective of the gradient. Another example I wanted to share with you briefly is the diabetes example. As I mentioned, we can't look at chronic diseases within their stovepipes, and from an equity perspective, we need to consider that the gradient holds true for disease outcomes as well as for social determinants like food and food security. So we want to decrease inequity, and that's the focus of what we're talking about here today. But we will end up coming to the point of asking ourselves, how do we know when we're done? So we really need to hold our vision in place. We need to hold where it is we're going. And this is where the concept of health equity is so critical. We're really looking to ensure that people can reach their full potential. And we're concerned, of course, with differences that are avoidable, systematic, and therefore unfair. So what does it mean to improve health equity or to integrate strategies that address health inequities? There's three things that we need to think about. We need to think about improving the conditions which influence health. We need to work upstream to alter the institutions, policies, and practices that cause inequities. And we need to make sure that we're aligning our interventions with social justice values. So we need to conceive of health equity as targeting disadvantaged groups, certainly, but we also need to think about the fact that we're closing gaps between groups and we're addressing the gradient. That is, we're not just focused on people who are marginalized. We're looking at impacting across the gradient, across the entire population. We often call this leveling up, this idea that we need universal policies as well as policies which are tailored and proportionate to need. So you'll see in one of the Let's Talk documents that we prepared, we focus on this idea of target approaches within universal. So I'd really recommend that you go and you take a look at this, because one of the things that we do know in public health is that how universal programs are implemented can actively increase inequity rather than decrease inequity. So we need to be paying attention to universal programs, but they have to be delivered in a proportionate manner. So the work of doing health equity, of improving health equity, means working from the downstream to the upstream. And the way that we like to think about it at NCCDH is we like to think that we're always trying to push upstream. There's need for interventions at multiple levels, ideally developing long-term multi-component interventions which reinforce each other. So it's not sufficient to be just working downstream. At the same time, we know that there are significant needs, and we can't only be working upstream. We need to be working at all points along the stream. So, of course, interventions and policies with the largest effect on health inequities are those which focus on addressing upstream or structural determinants, those determinants that I described earlier as patterning our access to social determinants. Interventions which influence both the processes which influence how health is distributed and those that influence health. So we need to shift our mindset and we need to shift our activities, specifically interventions which act upstream by addressing the root causes of inequalities are essential. And again, I would direct you to this document around moving upstream for more information and more details, which we don't have time for today. That's, in fact, a whole other webinar. So we need to move upstream, and no one really has said that better recently than Nancy Edwards. So this idea that it doesn't matter how effective we get at working downstream, at really trying to help the people that we see right in front of us every day, but we won't address inequities if we only focus on those, what she calls proximal determinants. We can't, as she says, tinker at the edges of structural disadvantage. We need to be focused and broaden our understanding of actions on the causes of health and illness and shift our thinking from behaviors and risks to determinants, which of course is a tall order. But we have a couple of resources that can help you, and you will see in particular the public health rules being referred to again in the presentation from Niagara, which, by the way, makes us feel very warm and our deepest level at NCCDH when we see our resources being out there and being used. So two resources I want to draw your attention to today. One is the Common Agenda, which is a document we released not so long ago, and it really draws on almost 10 years of work of us talking to public health in Canada and really trying to distill down to the essence of what it is we need to be doing collectively together in public health. So I'd encourage you to take a look at that. And you'll see when you do look at those three kind of, I guess, goals, high-level goals that we need to be working towards in public health. So building a foundation for action, establishing and using a strong knowledge base, which is one of the reasons why we're talking evidence and listening to Niagara today, and collaborating with non-health sector partners as part of our work. You'll see that the public health roles, which we'll be talking about today, really reinforce and guide us in the kind of work that we need to be doing on the ground in public health. And I'll just leave you with the Commission report, which is, I guess, just about 10 years old, coming up pretty quickly, that's really been guiding our work around the world. And that is that we need to be focused on three priority interventions and need to be thinking about everything we do through this lens. We need to be improving daily living conditions. We need to be tackling the inequitable distribution of power, money, and resources. That needs to be the common language that we use in public health in our world every day. And we need to know that we're making a difference. We need to measure and understand the problem and assess the impact of our action, and we can always do better at that work. So I'm going to leave you with that today, and I'm really looking forward to hearing from our colleagues at Niagara. So I think what I'm supposed to do is I'm supposed to bring this ball over to our next speaker. So I'm going to take it over to Nina.
It's heading over to Pam. Oh, yeah, to Nina. You're right.
Yeah, sorry, I have to drag this little, yeah, there we go, so that you can advance your slides. Thanks very much.
Hi, thanks, Susan and Leslie. And I'm just seeing if this is working here. There we go. Okay. So thank you to NCCMT and NCCDH for the opportunity to share about a qualitative program evaluation study that was completed very early this year at Niagara Region Public Health, and to have the final report as well shared called Recommendations to Address Barriers and Challenges in Utilization of Health Equity Tools in Public Health Nursing Practice. So my name is Pam Loff, and I'm sharing this as the investigator for this study. I am also a public health nurse at Niagara Region Public Health in lovely Niagara Falls area in wine country, and I have worked here for coming up to 9 years in the infectious disease program. I'm also one of the social determinants of health champions here at Public Health that have helped lead the work and development of staff training and our social determinants of health menu of tools, which is the focus of today's study. I also have the privilege of co-chairing our Health Unit's Priority Population Network, which is the group of frontline staff within public health that meet quarterly to share and discuss issues, resources, and strategies with input from guest community partners who work with priority populations. So as you can tell, I'm very invested in this topic and very grateful for these opportunities given to me at the Health Unit to address social determinants of health factors and health inequities in priority populations. So the objectives for today is to highlight the social determinants of health champion work on health equity tools done by frontline staff in the last 8 years at our health unit, and where we are now with this work and what are some gaps and questions, the study methodology, as well as the findings of the barriers identified by the participants, the public health nurses, in the use of health equity tools, and recommendation strategies to address these barriers. Funding-wise, I was given the privilege to complete this study through an advanced clinical practice fellowship from the Registered Nurses Association of Ontario, and as well as support from my organization, including directly from my manager, my primary mentor, our Chief Nursing Officer, Nurse Practice Specialist, and Senior Management for the time and resources to complete this study, and of course my colleagues, our frontline nurses here at the Health Unit, for participating and being open and honest, providing the feedback we needed to hear to move the work of health equity forward in our health unit at the frontline level. So I just wanted to take just a few minutes to give a background of the work that was being evaluated in the study. So we did a 3-phase approach for staff-led training and application of social determinants of health and health equity concepts and tools at our health unit over the last 8 years. So starting in 2009, our health unit adopted a strategic goal around poverty and formed an interdisciplinary committee within public health. And the committee agreed to start this work by building staff capacity on the knowledge of social determinants of health through educational workshops for public health staff. And this began the work of a peer-to-peer strategy for frontline staff to become social determinants of health champions, learning about social determinants of health concepts and health equity issues, and to share this knowledge with colleagues. So we did 8 voluntary workshops in 2010, which reached about 30% of the health unit staff. The objectives of this workshop were to increase staff knowledge and comfort in understanding SDOH and how it impacts individuals and population groups. And this was also then evaluated through pre- and post-survey of attendees. And attendees were asked about next steps, and the main feedback was that staff wanted tools to help with practical application of social determinants of health or SDOH knowledge and theory into practice. And then the organization continued to support the social determinants of health champion model in 2011 and 2012 under the Enabling Community Health Strategic Goal. And because of the differences in roles of public health staff, the social determinants of health champions decided a menu of tools was needed, or an inventory of tools was needed to meet various staff practices. So champions called it the Social Determinants of Health menu of tools. And the champions searched for these tools by reaching out to other health units, through success stories, in literature, and attendance at various conferences and workshops. And the SDOH champions determined which tools were applicable. The frontline staff in Niagara sized these tools into a hard copy format, which is in the picture on the slide. The method of dissemination was through a set of workshops offered in early 2012. The primary objective was to provide an opportunity to present the application of social determinants of health knowledge, skills, concepts, and theories through the introduction of this menu of tools, their inventory of tools. And then each attendee was given a hard copy of these tools to keep. And this included tools obtained from various sources, such as Waterloo Public Health, here in Ontario's Access and Equity Wheel, we adapted that. Ruby K, Payne's Bridges Out of Poverty Resources, adapted version of Sudbury District Health Units checklist, Robert Wood Johnson's New Way to Talk resources, we adapted as well, among a lot of other tools into this inventory that we have. And the purpose and application of each tool was discussed with attendees, who were then encouraged to take the tools back to their programs and work with the champions to implement relevant tools into their practice. So then, consistent again with the Enabling Community Health Strategic Goal in 2013, as part of Phase 3, the Social Determinants of Health Champion Group was given another opportunity to come together and take the menu of tools to the next step. So based on the evaluations from Phase 2, we did another one at 6 months after, as well as directly after the workshops. The champions created, based on that feedback, an electronic version of the Social Determinants of Health menu of tools. We called it the EMOT. It was not created as a module, but rather a tool that frontline practitioners can use as it applies to the work. So it was created to be interactive with capability to enter, save, and share work. And champions invited program teams to work collaboratively to integrate these tools into work plans. So instead of workshops, we did roadshows to team meetings. We were offered to all programs to present the EMOT. And a total of 10 teams received presentations at that time, with 4 out of the 6 teams in the Family Health Division received presentations, and 3 out of 4 of the program teams in Clinical Services divisions, where our public health nurses are, as well, received this presentation. So after the 3 phases were complete, we did do a post-6-month evaluation that was sent out to all public health staff with a response rate of only about 15%. It was done online through email. Of those staff who responded, and we made it clear in the survey to complete it whether you used any of the tools or the EMOT or none at all, 17.6 of the respondents reported use of the EMOT, which was down from 60% of staff who used the hard copy of the Social Determinants of Health menu of tools from Phase 2. So it is unknown if the difference is related to the delivery method or the type of the tools that are in there, but they are the same in the EMOT as in the Social Determinants hard copy. For those who stated they did use electronic applications, that they used it for similar, the similar tools that were in the hard copy tools and for similar purposes. And when asked about barriers, 90% of respondents did not identify any barriers to using the Social Determinants of Health EMOT, the electronic or the hard copy, perhaps indicating that more process and structure is needed. And then final results of this post-6-month evaluation was presented to our senior management team in the fall of 2015, and the next steps identified the need for process and structure to support staff in the application of these tools and continued engagement of the Social Determinants of Health champions. And a presentation to our divisional management team was also done in hopes of creating buy-in of the tools as well at the management level. And then, as noted in the previous slide, 1/3 of attendees at these workshops and roadshows were frontline public health nurses. And results from Phase 2 workshops and Phase 3 showed 2 tools that nurses who did state they did use tools used it, and mainly used it just to generate discussion and awareness among team members. And so, I mean, overall, though, the lack of uptake of these tools in practice was evident through these evaluations and also through observation by our champions as well. And since this time, our Social Determinants of Health champions continue to be engaged through offering twice-yearly workshops that combines all 3 phases into one for like any new staff or staff that want refreshers as well. And that includes the introduction of these social determinants of health tools and the EMOT. So the questions in the study was attempt to discover the reasons why social determinants of health are not being used through inquiry about the barriers and challenges in public health nursing practice within the organization, and also to inquire if there are other health equity-related tools being used, and understanding how nurses see health equity tools in relation to addressing health inequities and social determinants of health. And at the same time as the study, the Chronic Disease Injury Prevention Division has a team of members that are also doing a similar study, which Nina is going to talk about, on the 10 promising practices. So with health equity as an important focus of the organization, the new Ontario Public Health Standards coming, it was a great opportunity in regards of timing for this study. So the question this study attempts to answer is listed, what is the health equity tool lens? So I'm sure Leslie would be able to tell you a lot more about this, but the term health equity tools has been defined by equity lens in public health from University of Victoria, and we did use this with the participants, gave this definition as a document or resource that clearly identifies improving health equity as a goal and provides a set of steps, questions, or a framework that people can follow to achieve this goal. Of course, they created an inventory as well, published in 2013 of health equity tools based on literature search, environmental scans, and just recently released an update of this inventory this year as well, which has many more tools listed from Canada and internationally, and they're all health equity tools. So, but this project is specifically looking at the utilization of health equity tools in public health nursing practice, specifically looking at the social determinants of health menu of tools that was provided to staff, but we also did ask about if there were any other tools that they may have been using or how they even define what a tool is. And in review of health equity tools, the term is often interchangeable with the term health equity lens. In a quick review of the literature, didn't really see a set definition of what applying a health equity lens to practice looks like in public health nursing practice, but the Ontario Public Health Association in their position statement discusses using health equity lens as an approach that ensures health inequities are identified and addressed in any type of practice, whether frontline, program planning, decision-making roles. One of the approaches in their position statement recommends incorporating health equity tools in practice. So this could be at minimum asking a question about the project or the intervention or the policy and determining if it would further exacerbate health inequities within a population. One of these tools, of course, that's gaining in popularity through Ontario health units is the use of the more formal tools such as the Ministry of Health and Long-Term Care's Health Equity Impact Assessment, or HEIA. But I'm going to share with you today briefly the answers to these questions from the study, including the methodologies, the findings, and the recommendations from participants. And also to note the specific tools that we incorporated into our menu of tools have not been formally evaluated, and outcomes have not been measured as to whether they actually contribute to the population achieving health equity. Evaluation of the tools themselves on health outcomes and reducing health inequities is beyond the scope of this study. But would be interesting. So methodology-wise, so I did do a qualitative study, method selected of Thematic Analysis, which did myself and a project assistant did step-by-step and followed the step-by-step of 6 phases, including collecting, transcribing, coding, collating, interpreting, and analyzing the data. It was collected from participants, so public health nurses, through 4 focus groups and 8 semi-structured interviews using a moderator guide with probes and prompts, and a note-taker was present for 3 out of 4 of the focus groups, where the moderator also took notes for one of the focus groups that I didn't have a note-taker for. Interviews were conducted by the investigator as well as notes were taken. All focus groups and all but one interview was audio recorded and transcribed. The participant who was not audio recorded was member checked through the interviewer's notes, and audio recordings were transcribed by the lead investigator and project assistant, both. And transcriptions were then reviewed by both transcribers to the audio recordings after initial drafts and participant information was de-identified, and the lead investigator and assistant separately coded the transcripts inductively, and then codes were then reduced and collated with review for inclusiveness and mutual exclusiveness of data, and codes were reviewed and defined by the lead investigator and the assistant through consensus, often comparing definitions and naming codes based on, and we use often based on the barriers and facilitators that were identified in the Registered Nurses Association of Ontario Best Practice Guideline Implementation Toolkit, and data extracts were assigned to one or more codes as appropriate. So I did also, we used a process called Thematic Networking by Attried Sterling, resulted in the development of themes based on these identified codes. So thematic networking is an adjunctive tool to thematic analysis where codes are organized and grouped to develop a web-like network to visualize a summary of text and themes, which I'll show you in a few minutes. And through the web-like networks, investigators should be able to explain the findings and how they're interconnected to each other. And of course, there are limitations in the method itself, which are highlighted within Braun and Clark's document. The reference is at the end in my reference list. And as well, to prevent investigator bias, I did the project assistant coded, reviewed codes, checked codes independently, and we did together through consensus. Member checking of the final themes wasn't complete initially due to time frame that we had, but key themes have already been shared back to a group of participants since. And also management feedback was not obtained in the study, which could have provided valuable insight into the barriers of utilization of these health equity tools. It's, however, part of next steps now that the study is complete. So a little review over just the participants, but first I just want to highlight that recruitment of nurses into the study was very easy. It was evident in all of the focus groups and interviews that there's a passion within nurses for social justice and equity-seeking behaviors, and as the investigator and as a colleague, I was often approached by nurses who were interested in being a part of the study to share their feedback. We did attempt to schedule everyone who wanted to volunteer. However, due to short time frames for the study and the recruitment period, there were less than a handful of nurses who were not able to be scheduled in an interview or focus group due to scheduling issues. And saturation was reached at 29 public health nurses, all frontline, including one nurse practitioner. And nurses were recruited voluntarily through email invite initially, and then from other participants through either word of mouth or suggestions. And it was a purposeful selection of participants from all programs. We wanted all programs represented within clinical services and family health divisions and at a range of experience. So we tried to ensure there were at least 2 participants from each program as well. And you can see the median years experience as a nurse was 12.5, ranging from as little as 2 months experience as a nurse up to 39.5 years. And they were all female. We did attempt to get male, but again, due to scheduling conflicts, that it turned out the participants were all female at this time. And those of who attended can recall attending one or more of the social determinants of health workshops or roadshows from phases 1 to 3. And why we did not exclude participants who did not recall participating in one of the workshops is that we continue to offer twice-yearly workshops. So they may have attended one of those, or they may have as well have knowledge of the tools from other staff who introduced it to them, or it's embedded in their practice programs already, or we just want to know why they haven't heard of it at all. So we wanted to recruit anybody that was interested in nursing. So to go to the findings, the questions asked to the participants were the same, whether interview or focus group. Asking what a health equity lens means to them was the first question that was evaluated in here in the study, which was also part of the presentation you'll be presenting next as well. But they were asked how they address social determinants of health or health equity in their work. However, the main focus of the study was on the question of what are the barriers or challenges they face when using the social determinants of health menu of tools, with sub-questions focused on the common barriers that the Registered Nurses Associations document within their implementation toolkit highlights. And lastly, they were asked about what can the organization do to further support nurses in addressing health equity through the use of health equity tools. So the purpose of asking the question about health equity lens was to explore how participants view and apply health equity and their understanding on the purpose of using health equity tools. So it was evident from participants that they view health equity lens as intrinsic, is part of nursing values such as social justice. One participant stated, all of these issues were our issues before we even called it social determinants of health. Client-centered care, which is a nursing standard here in Ontario, was mentioned often by nurses as a means of providing equitable and accessible services by removing barriers to programs and services internally and externally. So in other words, from participants, it was often stated that addressing health equity is being able to empower clients and community to be able to make their own health decisions by having the knowledge and services they need without facing barriers. And the phrase "meet them where they're at" was actually stated by several participants throughout different focus groups and interviews when answering this question. And it was meant not only as a physically going to the clients, but also the importance of being aware that interventions also need to be individualized to meet clients' needs. So one participant stated they're in charge of what they want to learn, whether it's at a triple P class or wherever they are. So we'll meet them where they're at. We're not about throwing information at them. We're about what are their needs, what is your question, how can I help you. Understanding how the participants define health equity lens in practice was useful when considering the following findings of barriers identified by participants in the study. So during the focus groups and interviews, the hard copy of the menu of tools, or the EMOT, on our internal network was briefly shared for participants to look at and help recall memory. And participants were asked to describe any challenges or barriers in using social determinants of health, menu of tools, or any other health equity tools that they're using in their work that may not be a part of the menu of tools that we presented. But under this question, participants were asked questions such as the barriers of the tools themselves, like the complexity of them, accessibility, ease of use, individual factors as well, such as training, time, attitudes, team factors such as supportive team, priorities, workload, or resources such as budget, supplies, time, and lastly, organizational factors such as expectations, leadership, support, scope of practice, and competing projects. So resulting from this inquiry, there were 4 evident overall themes. And so in this slide, you're viewing the results as a thematic network. And this process took the final codes and organized them into global themes, which is the blue bubbles, and organizing themes, which are the purple bubbles, and the sub-themes or basic themes that make up the organizing themes, which are the green bubbles. And 4 barrier themes were identified as integration, resources, awareness, and prioritization, and a total of 9 sub-themes. And when collating and deciding on where codes fit, it was somewhat challenging to analyze due to the definition of health equity lens or tools in practice by the participants. So sometimes they spoke to the social determinants of health menu of tools when talking about barriers, or they spoke to other tools, not necessarily an assessment or set of questions, but tools as in specific roles like the outreach nurse as a tool, or tools to help address accessibility issues of programming, such as availability to provide clients directly with physical resources like bus passes or food, or availability of technology for clients. But most likely this was because as well the lack of familiarity with the social determinants of health menu of tools, or EMOT. And so we did include both of this in our graphics, so whether related to tools we were evaluating or to other tools as the nurses defined, the participants defined. So integration was a strong theme throughout the analysis. It was seen as an important facilitator by participants to increase uptake of these tools, such as into current assessments or current processes and planning. And many participants stated they already have cues and processes within their current screening or assessment tools. For example, the Healthy Babies, Healthy Children screen was brought up, or the mental health comprehensive assessments were brought up by participants, which cue the nurses to ask clients the questions about social factors such as income, housing, education, cultural, social supports to assist the nurse in considering what supports the clients may need. And then the analysis also confirmed that there are no specific examples of how the participants have utilized the social determinants of health menu of tools in current practice. So it is important to look at why this is so, and the 4 sub-themes identified have been a barrier to integration into practice is the time, obviously, to understand it and to implement it, to receive training on it, and as well compatibility of the tools. Some nurses said they're more useful in manager role, or some said they're more useful in case management role, not in a clinic setting. And at last, attitude or buy-in of the nurses. It was clear participants are not looking for an add-on type tool. The tool has to be evaluated and show how it improves the health outcome of clients with health inequities. Another barrier was on awareness, and was sub-themed into 3 different topics. First, in regards to health equity tools. So it was clear in the focus groups and interviews about half the participants were not aware of the tools or requested a refresher. Most participants did not even know that the department still offers the workshops that combine all three phases into a half-day workshop twice a year, and that it's also embedded in the public health orientation module. And also, there's general awareness as well of social determinants of health, and health equity was commonly brought up of participants. So they've noticed that there is an organizational culture shift in the last 5 years, and that has been a facilitator. However, the need for sharing of trends and data of local health inequities of priority populations was something stated as need to help inform decision-making and practice changes, and awareness of community resources and service. So again, not specific tools themselves, but for those participants who work especially in case management, the need of a tool to increase awareness of available resources internally and externally in the community. And then as well, resources, physical, and the role and scope as well. So like I've already mentioned about time, the role, outreach nursing roles, as well as physical resources as mentioned prior. And as well prioritization. So many participants agreed that there had been a shift in workplace culture and agreed that the addressing health inequities is viewed as important by the organization, but the utilization of health equity tools had not been prioritized at a frontline level. And so mentioned in both the post-workshop evaluations of Phase 2 and by participants is that there is no structure or process in place to use them. The majority of participants were not aware of other health equity tools as well, like the health equity impact assessment outside of the tools presented at the workshops if they attended that. And so that was a common comment from as well that was found through the study. So these are just the quotes that talk specifically about the tools themselves. So just keeping this feedback in mind, the organizational factors discussed above are limited to the perceived barriers of the participants. As these barriers have not yet been reviewed by managerial or senior management, the study is missing the context and decision-making input as to why these perceived barriers exist or how they're currently already being addressed. And at the organizational level, not all barriers are specific to health equity tools as well, due to the lack of examples of implementation of these tools and other health equity tools by nurses. There could be other barriers, too, that are not yet known, which would explain why participants answered the question of barriers more in regards to social determinants of health and health equity in general compared to the actual menu of tools. But these quotes, again, are specifically related. They're from participants in regards to the social determinants of health tools. So what does this all mean now? After asking about barriers, the next discussion was on supports or recommendations from frontline staff. So it's interesting to read about what other reports and literature and how this lines up often with recommendations from participants that will assist not only in the use of health equity tools in practice, but in addressing health inequities in general at a public health population level. And in our workshops, when discussing the tools, we also discussed the public health roles as outlined in the slide above, and this was taken from the NCCDH's, as you saw earlier, document, which is available on their website. And I think there's a link as well here. But as you see, most of the recommendations in the following slide can fall into one or more of these four roles. So just looking briefly, because I'm going to let Nina present on hers, but we do have some recommendations that have come out from public health nursing and support from literature. And so, I mean, a big thing with the tools was to evaluate the current social determinants of health tools that we have, and that because there are so many more, too, as the health equity lens in public health have put out their inventory, are these the right tools that we have in there? Are there other tools we could be using? And to actually evaluate them in practice and see how they improve health outcomes and can address health inequities. And as well, as participants were saying about having these factors more embedded into our health assessments and screening tools and databases to be able to gather the data so we understand more about the health inequities in our populations, which is happening as well in our in departments here at our health unit. And of course, the importance of engaging frontline staff in choosing tools, engaging in support, so continue to do that, support the social determinants of health champions to help to integrate them. And as well, it was also mentioned often about doing it in collaboration with community partners, so not just with internally, but also looking at how we can incorporate community partners as we look at these tools. And then in regards to awareness, obviously from the study it was very clear that that there still is some work needed on the awareness of these tools. As of this time, it's all voluntary. A lot of participants were requesting some type of mandatory training, so it could help address some of the barriers about getting the time in order to be able to do that. And awareness of resources and services as well was often brought up, of the different community resources and services internally and externally that can help address the needs of priority populations and working with them. And that's so obviously sharing more through the departmental network approach. The priority population network can be a strategy. Awareness of health equity tools and resources was often brought up. They would like to see more modules or team meeting visits or newsletters and having those regular reminders in there, and knowledge brokering of interventions that work to address social determinants of health and health equity in nursing practice and provide opportunities to develop other skills. A lot of participants said they'd like to develop more mental health competencies and cultural competencies. And of course, time was a big issue as well, and that's having that protected time for professional development and as well to understand and apply these health equity tools. And also looking at the role of the nurse as well and being able to provide for additional needs of clients that have health inequities as well was often brought up. And then lastly, the priorities, so development of accountability measures and indicators, and of course there's a lot of literature support for a lot of these recommendations. So, and to allocate funds to interventions that address health inequities, continue developing partnerships with community, with joint agenda to address health inequities, include clients in decision-making, planning process, and develop strategic direction on health equity. So the next steps were to identify, meet with key stakeholders within the department, so that's ongoing, and presented findings and recommendations in collaboration with the presentation Nina's going to give, and that which we'll talk about briefly after Nina's presentation. So I'm going to give it over to Nina to share about the project they did in the Chronic Disease Injury Prevention Division.
Thank you, Pam. So I'm going to take you through a project that was completed within the Chronic Disease and Injury Prevention Division at Niagara Region Public Health. Sorry, I'm just trying to see this technology to work. Anyways, so Pam gave a really great background into the departmental strategy, that EMOTs, and the different tools that we were trying to implement. So this project was in part developed as a result of limited staff uptake of previously introduced health equity tools as described by Pam. So like she said before, reported barriers to using health equity tools included a lack of formal requirements and process to support staff using the tools and adequate training for the tools. So what I'm going to walk you through is our process and the results of our divisional project on building knowledge, capacity, and culture towards health equities. So we're going to be covering Niagara's process, what we did with our division, our results, and our lessons learned, and then the shared recommendations between my work and Pam's work, or my group's work. So just to give you a little bit of project background, and Pam gave a great background, so I'm not going to go into this too much. Our region Public Health did embark on a social determinants of health initiative, and when that was evaluated, there was a low percentage of staff using the social determinants of menu of tools in their daily work. So in response to a question of how to increase uptake, some staff suggested implementing a process or a structure to support and guide the use of these tools. So based on staff feedback, we decided to focus on these barriers within our division in the chronic disease and injury prevention to see if there's ways we can increase staff understanding and capacity to intentionally address the social determinants of health through the 10 promising practices that were developed by February. And just to give you kind of like context to what Niagara Region Public Health and how we're set up, we are a two-tier government system, and we have 5 divisions within Niagara Region Public Health. And this project was just carried out within the Chronic Disease and Injury Prevention Division. And here's just kind of an org chart, so you can get an understanding of what our division looks like and the different topics that we are trying to tackle within the Chronic Disease and Injury Prevention. Okay, so the objectives and timelines for our health equity project. So phase 1 was 2016, and this is really just to assess the current state of health equity practice in CDIP using the 10 promising practices document as kind of our guide or our baseline for our data. And then after that, to create a summary report based on the key findings from the key informant interviews and share that with staff. And then phase 2 was to develop an action plan based on the results from phase 1. So for our methods, we did focus groups and key informant interviews with all CDIP staff and managers. We used a peer-to-peer approach, so project team members facilitated the focus groups and interviews, and the questions were developed in consultation with our epidemiologists. We also sought some help outside of our division, so we tested our questions with health promoters, our associate medical officer of health, and a director for another division to ensure that we were getting the right information. And so then we kind of tailored and worked on our questions throughout the whole project. So before we did the focus group interviews, we had to do a lot of building readiness to let people know that we were coming, that we were going to be speaking with them. A lot of people felt like they were being interviewed, so we had to kind of come out openly with everyone. So what we did is we presented at various staff level meetings. So we went to manager meetings, team meetings, we did a presentation at senior management. Our presentations focused on introducing the project and the 10 promising practices and emphasized how this was going to be developing an action plan and that we weren't there to criticize anyone's lack of use of anything, but we really just wanted to understand what our staff are doing and learn from them of how we can best address health equity within CDIP. So it wasn't really framed of what you're doing, but more of how can we learn from you and how can the organization support you in this work. One of the things that we did do is we created this visual graphic to help show the differences between some key health equity terms. The language we use in talking about these concepts is very important to ensure everyone's on the same page, and sometimes these terms are used interchangeably when they have very different definitions in a public health context. We use this tool when we were assessing the state of health equity work within our division to clarify terminology and to eliminate confusions around the definitions during the assessment. So in simplified terms, we thought, public health units can address the social determinants of health by using the 10 promising practices to achieve health equity. I'm not going to go over this in great detail, but these are the 10 promising practices that were developed by a subsidiary. They had program-level practices and also organizational-level practices. So the report describes the process and findings from subsidiary's district health unit. The project got evidence to guide health units to orient programs and services to reduce social inequities in health through an extensive literature review. The project identified 10 local public health practices that have potential to reduce social inequities in health. We use the 10 promising practices to guide our questions for our assessments of health equity work in our division. The first 6 practices were separated to program level. So those are the ones that we asked to Frontline. And then the following 4 are organizational practices. And this is where an organization will have an influence to support staff in achieving health equity beyond the control of the frontline staff. So just again to show to you, there's the program level practices that we use to assess frontline staff use, and then the organizational level practices, we developed a different set of questions for managers. So in terms of our data collection and interview setup, so each interview had 2 staff members and we had a summer student working with us. We kind of debated between key informant interviews versus focus groups. And because we have such a diverse number of staff in CDIP in different topic areas, we did land on the majority being key informant interviews, so one-on-one interviews. And then we did do some focus groups with some of our groups of staff, like our tobacco control officers and our MIN staff and the summer students. When we went to develop the questions, we engaged our epidemiologists, we focus tested them, and like I said before, we did program-level questions for staff and organizational-level questions for managers. In total, we did 32 interviews. We could not have done this without student support. We had a wonderful student that came to every single one of those interviews and took full notes for us. and then we had a backup staff member that was also taking notes so we can compare them to make sure we didn't miss anything. We had decided not to audio record the interviews, and we just did the note-taking. We also engaged office support. So we had one of our admin assistants email out staff. They emailed out all of our graphics and all the information. They did reminder emails before their interview, and then post-interview thank you. And then we revamped questions and process as needed. So if we're finding that we weren't getting the answers that we needed, we did revise the questions. So this is what our note-taking template looked like. So this is what our student used to create notes and the backup staff member. When it came to analysis, we decided that we would do themed analysis for open-ended questions, and we developed a rubric system for the assessment questions. So if you look at it, so what we did is we had a 1 to 4 scale of the concept not described and examples not provided, all the way up to provides examples and descriptions of how it applies in portfolio work. And sorry, I think I'm getting, oh, okay. I just saw someone that said something that they're unable to hear me. Is everyone, can someone confirm that they can still hear me? Anyway, I'm just going to continue talking.
It's Susan. I can hear you, Nina.
Okay, sorry. I just saw one of the chats on the side. So
yeah, I think you're good.
Okay, thanks, Susan. Okay, so like I said, we had this rubric system where we assessed on 1 to 4. So as we read through the responses that were provided by our staff members, we would assess whether or not there are 1 to 4 on this scale. And then the themed analysis, what we did for that was, well, actually, I'll describe that in a minute. What we did for the themed analysis is we had one person reading through and pulling out a keyword or word or code per concept. And then we had a project team member conducted the keyword coding analysis recorded on a Excel spreadsheet, which is shown here, but it got a little wonky in translation, I think. And then we had a second project team member analyze the results to see if there's any other additional keywords that maybe the first person missed. And then after that, the whole project team got together and we used the keywords and we grouped them into themes by consensus. So on to our results. So when looking at the program level results, so these were the rubric ones. So the findings demonstrate that the CIP staff are excelling in implementing the majority of the 10 promising practices. Our staff understand the importance of social determinants of health, and they regularly consider them in their daily work. Our programs, campaigns are often tailored to meet the needs of specific populations. However, there were some that we scored lower on, and that was purposeful reporting and social marketing. So when we were looking at our action plan, that was somewhere where we could put some focus towards. When we look at the thematic analysis, what our results indicate is that all of our staff need the following factors for success to be adopted at the departmental level to address health equity. And that is clear permission and direction from leadership, and that the health equity work needs to be intentional. So we heard a lot from people that they understand health equity, they understand that they need to focus on it, but they're really looking for that guidance and direction from their leaders and from the leadership team to say, yes, this is a priority for our health unit and this is where we should be focusing our time, and that it needs to be intentional, that it cannot be done at the side of our desk, that we need to be intentionally planning for it. So then the 6 themes that emerged from all of the interviews from frontline staff and managers is that program planning, management accountability for addressing health equity target setting, knowledge exchange and partnerships, data and communications. So for CIP, what we saw was, that leadership intention needs to be there. For program planning, something easy that we could do would be that CDIP management and staff commit to incorporating health equity into their operational planning and work plans. So some thoughts around this was to develop a planning guide that not only walks you through like an evidence-informed cycle, but it embeds health equity throughout it. In terms of health accountability, that our CIP management team commits to building and supporting a strong culture of health equity. So that's that's ensuring that they're keeping their staff accountable for addressing health equity, and that the managers are accountable as well. For health equity target setting, CDIP management team adopts the use of target setting for accountability and to ensure resources are used efficiently. And I should say these were just, this all came from the focus group. So this is what our staff is telling us they would like to see, and we presented it to our managers, and we're still working on the action plan. So none of this is actually set in stone nor approved, but this is what our staff told us that we need to do. For knowledge exchange and partnerships, that the management staff raises awareness regarding the social determinants of health and health equity through reports and in the community. So this will be any reports to our council, when we're collaborating with external partners to really try to show them the data through a health equity lens. In terms of data, that we work with our epidemiologist unit to develop a social determinants of health data plan. We did find that a lot of staff just didn't know what local data we have or what data they should be using to look at the social determinants of health. And then in terms of communication, that we work with our communications to develop a social marketing plan that specifically addresses, social marketing plan to specifically address social media. Sorry, got a little tongue-tied there. Okay, so as Pam showed before and Leslie was speaking about earlier, those 4 roles for public health in terms of assessment report, modifier-oriented interventions, collaboration, and policy development, we picked some key activities that could fit under there so people could see how their roles and what they can do to address health equity. So in terms of assessing and reporting, so integrating to work planning, working with the epidemiologists on local data needs, and including social determinants of health and data reports. In terms of modifying oriented interventions, our staff should be working towards targeting with universalism and using social media and so forth. So we thought this was just a really good way that people could actually see their work into those roles. In terms of lessons learned, this was a big project. Like I said, on our project team, there's about 5 or 6 staff members, and we had 32 interviews conducted, so logistically, there was a lot of work to do there. In terms of cross-functional team, so within CDIP, we had members from every single one of our teams working on this, and we had health promoters, I'm a policy advisor, we had our project coordinators, we had a pretty diverse team working on it. We had to ensure that staff were perceiving this as a positive and they weren't seeing that this was like an interview and that they were going to be criticized for using or not using health equity tools properly. We had to capitalize on readiness. So as Pam said before, there was a lot of departmental work on social determinants of health with our champion work, so we knew, and with the new standards, there was a readiness for this. We had to make sure we had the capacity to conduct the process. So this took, for the project team members, this was our work for a good 4 to 6 months, and we had the permissions from our managers to dedicate our time to doing this, and then also evaluating our project as we went along. Okay, so our HEAP team members, I just wanted to give a shout out to my folks in CDIP. So there's Catherine Houston, Marty Mako, Bianca, our student, Lindsay Garofalo, Victoria Hull, Melanie Sagan, and David Lorenzo. And then finally on to share recommendations. So you heard from Pam about her project. There was also another project within Niagara Region Public Health around health equity, and that was an actual, our physician engagement coordinator was doing a project with one of the family health teams on income screening. So we knew that there was these 3 projects concurrently happening at Niagara Region, and we decided that we would do a joint presentation to our senior management team to show them that our results in the CDIP project and the results from Pam's project were very similar. And the things that were coming out was that to achieve health equity, you need leadership, accountability, training, and collaboration. And so when we presented to our senior management team, we were saying, you know, these 2 very different projects came out with very similar themes. And what was great was that we had really wonderful support from our senior management team. They agreed as well. And so in terms of next steps, there is a departmental working group to develop and implement a health equity strategy. So when I talked earlier about our Phase 2 being an action plan for the chronic disease and injury prevention team, we're actually just going to be rolled into the departmental one. And the departmental strategy will use the information gathered from these projects to inform their health equity strategy, which is great. So now we have an even more multidisciplinary cross-cutting team to work on health equity at Niagara Region. I hope I didn't talk too fast. I wanted to make sure that we had time for Q&A. And so I will pass the little ball over to, who am I passing it to? Health Evidence?
We'll pass it, I'm going to pass it back to Susan right now.
Okay, I didn't see Susan. Oh, there we go. Thank you.
Great.
So it is Susan Snelling here, and thank you so much, Nina and Pam, for sharing with us the work that you've done at Niagara. And, you know, to me, one of the really key takeaways is that although tools are important for creating some of that shared process and moving the organization forward, you need that, as you said, the intention, right? You need to use those tools on purpose and have the direction and the permission to use the tools and really have a way of having them incorporated into your process. So really interesting lessons, I think, for all of us who are interested in ways to bring a health equity lens more directly, more clearly into organizational level work. Certainly tools are going to be part of that, but you also need that supportive context. So really great lessons that came out of the work that you did. So thanks so much for sharing that. I would invite people to put questions and comments into the chat box. I think we've got a couple sitting there that we'll get to, but we'll just talk very quickly about a couple of resources while the questions come in, and then go from there. So one resource that we really like to make people aware of at the National Collaborating Center for Methods and Tools is this one. It's called Is This Evidence Useful to Me? And it's really a guide to looking at research evidence and adapting it to your local context. And in particular, will this work to advance equity considerations? So you'll see here questions like, does the intervention reduce or exacerbate health inequities? So some other questions listed there as well. It's really just a prompting tool so that when you are trying to use research evidence in making decisions about what to do, you're sure that you're asking some of those really key questions about equity. So certainly draw your attention to that tool. You can also find the link to this tool on the NCCMT website in the registry, but I've given you the direct link there to CRICH, which is the Center for Research on Inner City Health. And then Leslie, maybe I'll just advance the slides here, but there are a couple of tools that you wanted to draw people's attention to as well.
Yeah, thanks, Susan. I think I did in my discussion of social determinants. So I think in the interest of time, we can leave this for people to use the links in the slides, if that's okay.
Great. Okay, so we're just seeing here a couple of references, Setting a Common Agenda for Public Health Action, and the Let's Talk series, particularly this one on advocacy and health equity. So now to some questions. So please use the chat function, and we'll get to your questions right now. Please send your questions to all so that we can all see those. Thanks.
That's great. So we have had a couple of questions trickle in, so we're going to go back a little bit. One question was about saying that the answer to the question about what is a health equity tool or lens was really telling. It seems like it might not be the awareness of the tool or lens, but more about asking about how we change practice to promote health equity. So awareness of the isms, racism, gender inequity, how we prioritize working with disadvantaged families, how do we influence upstream factors that influence community health. Does that resonate with your experiences?
Hi, this is Pam. Thank you for that question. I found the question about what a health equity tool lens was very interesting as well, how it was answered from the nurse's perspective for participant-wise, and how a lot of it was focused on addressing barriers, and that seem to be barriers internally within our own programs, and also addressing barriers out in the community as well. And that could be certainly the isms as well, addressing racism, gender inequities, and whatnot as well. So certainly it does resonate with our experience here within the study with nurses.
Wonderful. And then somebody asked, yep. Okay, so somebody did ask for an explanation of the phrase targeting with universalism.
Okay, I'll do my best, but Susan, feel free to jump in. This is Nina, by the way. So the way we looked at it was if you have like a universal program that is for everyone, you can still target within there. So looking at, when you look at your data, if you see something like, I don't know, like males at a younger age or more affected by whatever your campaign is on, you would target towards that group. Does that make sense?
Great, thank you. And just because we want to keep things moving, we've had a couple of people ask if the menu of tools that Niagara developed, is that available for others to use and see?
I mean, we can certainly share, like, because the tools is really an inventory of tools, so they're not necessarily our tools. They were created by other people, but we could even send the links of what an inventory of what all the tools that we are using are, and we can maybe even try to send some screenshots. But it is saved, and our EMOD is on our internal intranet network, and that's so it's not something yet that we can share, but that is something that we've discussed in the past about having that available in order to work with community partners. So certainly if it does become available, then we can share it that way. But for now, I mean, we can certainly share which are all the tools that are in that menu of tools that we use.
That'd be great. In order to get in touch with our presenters, you can email us at nccmt@mcmaster.ca, and we can connect you with presenters. That info will be posted in the chat as well as on one of the final slides. There was another question, I think this might be our last question that we can have time for. Is there any thought to doing other studies or interviews within other areas of Niagara Public Health? The commenter works in environmental health in BC, and they're challenged with incorporating an equity lens within a legislative framework. And he was curious to see how others might be handling it, if at all.
So as I talked about before, we do have our health equity strategy that we're developing in Niagara, and we do have representatives from environmental health at that table. For right now at Niagara Public Health, I don't think we have any plans to do this rigorous of like a focus group interview type process in these other divisions. However, as we go through our health equity strategy, that may be something that we may need to consider for finding that, you know, some department or some divisions aren't need some more support.
Perfect. And then I guess one final question here. This might be a question for Leslie. The commenter said he'd like to see another webinar expanded on the topic of social justice values. What does that mean in a public health environment? We don't recruit or assess staff based on their values when approaching this type of work, and should we?
Yeah, that's questions from Marty. Thanks, Marty. Great question. And if we had lots of time, it'd be great to go into it. But I guess I would just challenge that we don't hire people based on values, because if we do hire people with public health practice, there are who are trained in public health, and we have competencies in public health, and we're very clear that social justice values are part of the public health competencies. So, yeah, I would say that we do hire based on that. It's just how do we articulate that, and we can, yeah, talk more about that in another webinar.
Wonderful. So I will close the Q&A session now. If anybody has any burning questions, please feel free to email us, and we can get you in touch with the right people to answer those questions. Your feedback is very important to us. I'm really pleased to say that this has been one of our most popular webinars, and we are really interested in your feedback also on what else we could feature. And if there's somebody in the audience who works in similar topics and you'd be interested in presenting your story, please contact us at nccmt.ca for the contact information there. There is a short survey available. I believe it'll open when you close your webinar window as well. The link is also posted in the chat section. Please, it takes really just a few minutes, and we really do value your opinion on that. If you are able to take a look at the slides on WELL, there are a number of other slides that do detail some of the resources available at nccdh.ca as well as at nccmt.ca. So please feel free to check out the websites for more information. There's a lot of really great information there, especially in terms of equity at the DH website. So we have Leslie's email on the screen right now. You can also follow NCCDH on Twitter. And then in closing, I will post NCCMT's contact information as well. Our email address is there. I believe Claire is posting all of the contact information in the chat window as well. So thank you to everybody who joined us today. We really do appreciate you joining, especially at the modified time. I will pass it back to the presenters to see if they have any more comments before we go, but thanks again to everybody who joined and participated. We do appreciate the discussion. Thank you so much, and we hope to see you for the next one.
Thank you very much.
Thank you.
Thank you.
Thanks, everyone.